So DDH, or developmental dysplasia of the hip, encompasses a spectrum of disease, anywhere from pediatric to childhood disease and dislocation to skeletally mature adults with mild hip dysplasia. So dysplasia in general means a shallow or underdeveloped acetabulum, and it could also be involved with subluxation of the hip or dislocation. These are more common in the pediatric disease. And teratologic hip, which are hips that are basically irreducible on exam. These are the most severe hips. The babies are born with the hips dislocated, and oftentimes they don't reduce, and there's a pseudoacetabulum. This can be seen in common genetic diseases. So again, as I mentioned, it encompasses a spectrum of disease, including this skeletally immature dysplasia, which a lot of times you can't pick up in childhood even with screening. The reason, or the epidemiology, the incidence, it's the most common orthopedic disorder in newborns, and actually, besides all cardiac disease, it's the most common newborn disease. Dysplasia is present in about 1 in 100 people, and in skeletally mature, even some studies have shown it's common more, especially in females, when you look at asymptomatic people. But there's dislocation in about 1 in 1,000. It's more common in left hips and in females. It's bilateral in 20%. The risk factors are firstborn, female, breech, family history, and some sort of packaging issue in the uterus or low fluid. And so if you look at people that are most at risk, it's firstborn females, and breech and family history are close second. The pathophysiology, the initial instability is thought to be caused by multiple factors, both maternal and fetal laxity. There's genetic laxity, intrauterine and postnatal malpositioning. So, for example, a hip may be normal, but towards the end of the gestation period, just with the packaging problems, you can get dysplasia that occurs just from the position of the leg, and you can even get it after the child is born from severe swaddling, and that's why some cultures that used to swaddle had more dysplasia, because if you take a hip that naturally wants to go out to the side in the frog position and you force it in, it could cause some lateral laxity. And it's usually the problem is in the anterior lateral aspect of the hip, except perhaps in cerebral palsy, and this is a question often asked, acetabular deficiency can be more posterior or superior. So anterior lateral is more common, but in certain diseases it can be more posterior superior in the neuromuscular hip. Associated conditions are congenital torticollis, metatarsus adductus, or knee dislocation. Anything where the child is squeezed in the uterus, that's what's called a packaging problem. So the hip isn't free to move around and form normally. Also, it can be in conditions with increased amounts of type 3 collagen. Again, it's a spectrum of disease. And at birth, it's either dislocated, dislocatable, or subluxatable. So dislocated means the hip is out at rest, and Ortolani positive means you can put it back in. Ortolani negative means it's dislocated and you can't put it back in, so it's irreducible. A dislocatable hip is one that at resting position is inside the joint, but with a maneuver of a Barlow maneuver, you can dislocate it, and then it comes back into the joint. And then there's subluxatable, which I think is hard to examine, but perhaps when you're examining the hip, you can feel a little laxity. So here's a test. So basically a 1-month-old infant. What is this maneuver? Well, here the hip is dislocated, and with abduction and pushing up on the greater trochanter, you can feel it reduce. This is the Ortolani sign. And how I remember it is O means it's out. Ortolani is out, so you can reduce it. Now, a hip may be dislocated and unreducible, and that's more the teratologic type hip. So physical exam under 3 months, or the newborn, is basically the Barlow and Ortolani maneuvers, looking for instability. So again, a Barlow is a hip that you can dislocate, as you can see up in the upper right here, where you can dislocate that hip. Green arrow, if we have it, please. Where you can see the hip being pushed out the back. There you go. So an example, so here the examiner is adducting the leg, and it doesn't require a lot of force to sort of push posteriorly and almost take the trochanter and push it out laterally. You can feel it come out, and then when you bring the trochanter forward, and when you abduct, it goes back in. So it's more of a it's more of a shucking maneuver than it is just like push it out and bring it back. So what I do is I sort of push down and out, abduct and adduct to see if you can get the and push your finger on the greater trochanter, see if you can push it in and out. Basically, Barlow is a dislocatable hip, and Ortolani, again, is a dislocated hip that you can relocate with abduction. Another mainstay of physical exam is the Galeazzi sign. And this may be more common in older children, but you can see here when you flex the legs, this femur is shorter than this one. And the reason is because this hip is dislocated posteriorly. And it's a good thing to look for a unilateral dislocated hip. In general, hip clicks are nonspecific findings. There's no association of hip clicks with a dislocation. And the Ortolani and Barlow, after 3 months or so, the hip becomes fixed in that position. The ligamentous laxity around childbirth goes away. So the Ortolani and Barlow maneuvers may be negative, but you can still have the hip dislocated. And I think the hardest one to find are the ones that are both out that you can't reduce because you don't have a Galeazzi sign. So in general, both hips will be the same length and you can't reduce them. So that's the teratologic hip that can often be missed. Now, in children that are older, once the exam, the Ortolani and Barlow exam are negative, you have to look very closely at the physical exam. So limitation in hip abduction is one of the most common findings, or a leg length discrepancy. So when you're examining this child, you should completely get them down to the diapers and ask and just get a good look. And if they're walking, you should watch them walk. You're looking for pelvic obliquity or lumbar lordosis, especially if both hips are dislocated, or a Trendelenburg gait or toe walking on one side but not the other. So here's another question. This is a child born by breech presentation. Again, a risk factor. And the ultrasound of both hips was performed at 6 weeks of age. How would you interpret these findings? So here is one hip right here, and you can see here's the femoral head, here's the lateral acetabulum, here's the ilium, excuse me. So this is the ilium, this is the acetabulum, it's like an AP pelvis on its side, and here's the femoral head. So if you look at this one, this femoral head is covered a little less than 50 degrees, and something we call the alpha angle, which is the angle of the lateral ilium through the femoral head, as well as the supraacetabular roof, and it's this angle. And this angle is considered to be normal if it's 60 degrees, but an alpha angle of 47 degrees is slight dysplasia. Now, an alpha angle of 47 degrees in a newborn may be normal, but at 6 weeks of age, it should normalize. So the answer to this question is the alpha angle is normal on the right and abnormal on the left. So the right hip is normal, the left hip is dysplastic. And if we go back to it, you can see this hip is extremely well covered, and the acetabular roof is this angle, the alpha angle, right? Let me get this angle right here. The alpha angle is higher at 62 degrees. That's normal. This is less of an angle. There's no room for the femoral head to sit down inside. So this is a dysplastic hip. So ultrasound, this is the primary imaging we get from birth to, I would say, up to 6 months. So the diagnosis is a physical exam and ultrasound. Those are the two keys to diagnosis in the newborn. So the American Academy of Pediatrics, as well as POSNA, recommends an ultrasound study at 6 weeks in patients who are considered high risk. So that's a family history or breech presentation, despite a normal exam. So if a child's born breech and their exam is normal, they should come back at 6 weeks for an ultrasound screening test because their risk is higher for dysplasia than the general population. In general, though, if the hip is dislocatable at birth or Ortolani positive at birth, you don't need to wait to 6 weeks. You need to just start treating. If the ultrasound can also be used to monitor Pavlik harness treatment to see how it's working. Most studies, though, show it's not cost-effective to screen every child. Some countries do, but in the United States and North America, we found there won't be enough positives to treat. So the ultrasound looks for acetabular dysplasia. It looks for how much of the hip is covered. Clicks will often be normal. So if you refer to click, that can be a normal finding. What we're looking for is a dislocatable hip. So to review, anybody with a risk factor that has a normal exam should get ultrasound screening at 6 weeks. Not at birth because there'll be a false positive, but at 6 weeks of age. The measurements we take, and this was given to me, this is not the alpha angle. The alpha angle is this line with this. So this angle right here is the alpha angle. And this can also tell you, so if you look at this femoral head, the coverage is only 10%. It should be at least 15%. So it's an angle created by lines of the lateral ilium and the superior aspect of the acetabulum. And you want the femoral head to be bisected by this line of the lateral ilium. So here's another question. Which of the following is true regarding the structure? So this is, when you're looking at a hip, there's a lot of things that we can see. So here, this structure right here is called the teardrop. And the teardrop, at some point, you can see it's better on this side, but you can see it's concave. And it's concave because the femoral head's pushing on it. And that's more of a normal hip. So in normal hips, all children usually have this finding by 18 months of age. And if that teardrop is actually shaped like a V, then that's a hip that's is more dysplastic because it hasn't had the femoral head pushing on it. Now x-rays, so once they're older, I say 6 months of age, we get x-rays. The ultrasound, because the femoral head starts to ossify, is not as good. So at that point, we start to get radiographic x-rays. So after 6 months, x-rays is the primary imaging modality once the femoral head begins to form between 4 to 6 months. So you also would get it if you see a leg length discrepancy when you're looking for a child. So the recommended view is just this simple AP pelvis to screen. So here's the x-ray. So which of the following best describes the measurement labeled number 1? So if you look here, this is the medial femoral neck right here. And here is the inferior portion of this superior ramus. That should be a line that's fairly continuous, like an arch. If you look at this hip, it's broken. And so that's called a break in Shenton's line. And most people get that. And what we found, Shenton's line is not I wouldn't consider Shenton's line to be an important predictor until a child is at least 3 or 4 years of age. We use it a lot in skeletally mature dysplasia to say if the hip is subluxed or if there's a break in Shenton's line. We know that hip's in trouble as they get older. So I think in a 4, 5, or 6-year-old, a break in Shenton's line is more important than a 1-year-old. So let's look at some radiographic measurements. So here's an x-ray, and these are the typical x-rays we get. So Hilgenreiner's line right here is a line, a perpendicular or a horizontal line through the superior aspect of the triradiate cartilage. Perkins' line is a 90-degree to the Hilgenreiner's line, and it's at the lateral edge of the acetabulum to 90 degrees. And basically, you want the femoral head like a fast pitch, down and inside. So you want it medial mostly to Perkins' line and mostly inferior to Hilgenreiner's line. So if the femoral head is in this down and inside quadrant, that's a good hip. The acetabular index is an angle formed from, basically the acetabulum sourceal, which is the weight-bearing portion of the acetabulum. Sourceal means eyebrow. So it's the darker line that comes around. And this sourceal is bony here, but there's cartilage way out here. But in this age, while the acetabulum is developing, it's mostly bony. So it's the acetabular roof and Hilgenreiner's line. And this angle should be somewhat less than 25 degrees by 6 months of age. And it should be improving in children that have had treatment. Now, when people become more skeletally mature, here's an example of the lateral CE angle in an immature child. I personally don't get it till they're skeletally mature because I think there's a lot of variation. But basically, the lateral center edge angle of Weiberg is a center of the femoral head and a line basically straight up, and then which is 90 degrees to Hilgenreiner's line, and then from this point to the lateral aspect of the sourceal, and that angle, at least in skeletally mature people, should be under 25 degrees. And again, the acetabular teardrop is usually not present in this age, but you can see in the younger children, but about 4 to 6 months, you can start to see the teardrop forming. This teardrop looks fairly good. It's nice and concave. So we have ultrasound and we have plain x-rays. Those are the two modalities, ultrasound till 6 months of age and x-rays after that. Now, when we start treatment, we can do other things to look at the hip, and one is an arthrogram. And the arthrogram is basically done under anesthesia you put, under anesthesia, you C-arm to put a spinal needle in the hip and add arthrogram dye. And what it tells you, since the femoral head isn't ossified, is what's going on in this hip. If you look at this hip, it's fairly well reduced, and you can actually see, because there's a defect right here, that's actually the limbus or labrum that's downturning, and this thing called a thorn sign, which comes straight up. So that's a fairly normal looking acetabulum. So we would use the arthrogram to confirm reduction, and I also use it to see if the hip's unstable. Again, confirm reduction, and then in certain cases you can look. So this dye pool comes down here. For some reason, if the dye came, if the defect came down here, you'd say that's a labrum that's inverted into the joint, and that's going to be hard to reduce. So here's an example of a hip that's dislocated, and you can see the hip actually goes inside here, and you can see it's up and outside of the joint. And if you try to move the hip in, it will hopefully sit inside, and this dye will be moved to around the femoral head. You can sometimes see an hourglass constriction right here, and that's the iliopsoas tendon. Now, when we treat a patient, we want to see what if the hip is reduced. So CT scan was historically the study of choice to see if you treat with a closed or open reduction that the hip was reduced. But now we're using MRI as well to see if the hip is reduced, because you can see the soft tissue. We will also use MRI and CT in skeletally mature people to define the anatomy and look for cartilage and labral injuries. So when we screen, all infants require screening, and physical exam is the most important part of screening. So all children should be screened until walking age, and the Orlani and Barlow maneuver is the most important thing to do. We talk about ultrasound in patients at 4 to 6 weeks of age if there's risk factors or a positive physical finding and you want to confirm it. Okay, so here's a 2-month-old, has diminished movement in the right lower extremity. They've been treated in a Pavlik harness, so they can't extend the knee. So one of the complications of the Pavlik harness treatment are femoral nerve palsy, as we'll get into, because the hip is flexed. And in this case, the answer was loosen the strap right here to allow the leg. My personal thing is to take them out of the harness and allow the femoral nerve to recover, which it does in a week in the majority of people. So regarding treatment, any child with an Ortolani and Barlow positive hip should be treated, and I consider treatment by 2 weeks of age. You can do it right at birth in some centers, or you should have, if it's unstable, it should be treated within 2 weeks of age. If the hip is dysplastic, if there's a question, if the hip is not normal on ultrasound, so say it's stable, and the hip is stable, but you have findings of dysplasia that's not improving on ultrasound, you should treat it by 6 weeks of age. So in a screening, if you have dysplasia, you should treat it at 6 weeks of age. So anybody with DDH under 6 months of age, the initial treatment is a Pavlik harness. It's a dynamic splint that actually uses the muscles and how the kids move to reduce the hip. Its success is 90% in some hips, but it could be a little less in bilateral hips, male hips, right hips, or teratologic hips. It may not be 90%, but in most Ortolani or Barlow reducible hips, it's fairly productive. If it is not better by 3 to 4 weeks, and this is a very common thing, you need to remove the Pavlik harness and try something else, which is usually a semi-rigid brace. So the goal of the Pavlik harness is an early reduction. Once it's reduced, then you should keep them in the Pavlik for at least 6 weeks until the ultrasound normalizes, then you can wean. A good position in the Pavlik is greater than 90 degrees of hip flexion. One of the complications is if you have hyperflexion or you force the hip in, then you can get avascular necrosis or growth abnormalities or a transient femoral nerve palsy. And in that case, that's why you see them every week to make sure they're kicking. You have to take them out of the Pavlik, or you can consider loosening it. So also, if it's not getting better, if the hip hasn't reduced and ultrasound confirms it by 3 to 4 weeks, you want to discontinue the Pavlik and switch to something else. Once it's stable, and I have them wear it full time for at least 6 weeks of stability, once we confirm it's stable, then we can start a weaning process, and that's surgeon dependent. So the next question, a 4-week-old who's born with a dislocated hip has been treated in a Pavlik harness since 1 week of age. They've been compliant. So after 3 or 4 weeks, this is what your ultrasound looks like. Your exam may be fixed. You may no longer have an Ortolani or Barlow positive hip, but you have this ultrasound. And you can see from this ultrasound, here's the femoral head, which belongs down in here. So in this case, you want to abandon the Pavlik harness and consider something else and convert to a semi-rigid brace, which works in my practice at about half the time, sometimes more. So let's say non-operative treatment such as bracing and infantile doesn't work. Well, then the next option of treatment is closed reduction and spica casting, and this is best in DDH 6 to 18 months of age. And when you do a closed reduction, you want them in this position here, which is the legs flexed at least 90 degrees, abducted 45 degrees, with the hip nicely reduced, confirmed on CT and or MRI. And the key point is a medial dipool less than 7 millimeters. And all that means is it's not sitting out here, it's sitting deep within the socket. This is done under general anesthesia, and you do an arthrogram to confirm reduction. Again, you want the hip flexed at least 90 degrees and abducted 45 degrees. We continue it for 6 weeks, and then we'll do a cast change at another 6 weeks. And you want to confirm the reduction with a CT or MRI. So here's a patient with DDH who required closed reduction at 9 months of age. What is the recommended treatment? So for example, I don't see the x-ray coming up. Sorry about that. Anyway, so once the hip is reduced, you have to follow the hip over the years to make sure the acetabulum is forming normally. Now, if closed reduction fails, or if it's an older child, you have to do an open reduction. So it's usually in kids older than 18 months of age or failing a good closed reduction. And for open reduction, my preference is the anterior approach, where you can remove the impediments to reduction, reduce the hip, and perform a capsule, or you can tighten the hip capsule. There's another approach, which is the medial adductor approach, which is a variation of the Ludloff. And pros, you can do both hips at the same time. It can be perhaps done in younger children, but you can do an anterior reduction in younger children and less blood loss, but I think there's less blood loss in both. But if you look historically, the pros were always to directly address the impediments to reduction being the iliopsoas tendon, the medial hip capsule, and the pulvinar, but you can't do a capsulorrhaphy through the Ludloff approach. And it can be done in younger children, but I still think you can do the open reduction anteriorly in younger children. And they said less blood loss, but you don't have a lot of blood loss during the open reduction. The cons, you can't perform a capsulorrhaphy, and the medial circumflex is close, so there may be a higher incidence of avascular necrosis. The open reduction, the key point is to remove the anatomic blocks to reduction, which are the iliopsoas tendon, the hip capsule, an inverted labrum, the pulvini, hypertrophied, and ligamentous teres. Once you reduce this, you can get the hip nicely reduced, and this will allow you to perform your capsulorrhaphy and put them in a spica cast. So this is a 20-month-old girl with this found to have a dislocated hip. Now at 20 months, she's now a walking child. So at this point, I don't think a closed reduction would be indicated. So you would do an open reduction, and then you'll have to decide how stable it is, or if they're old enough to perform a pelvic osteotomy to try to decrease the need for later pelvic osteotomy. So usually in the children that are walking age, or at least age 2, we also perform an acetabular osteotomy. And sometimes we'll perform, we'll have to shorten the femur to make sure the hip is stable. So the answer to this is open reduction capsulorrhaphy with or without a pelvic osteotomy, or with or without a femoral osteotomy. So certainly in the older children, more than 2 years with severe dysplasia, accompanied by significant radiographic changes, this needs an open reduction and a pelvic osteotomy. We definitely, in any child over 30 months of age, we do a femoral shortening and a pelvic osteotomy at the time of open reduction. So 18 months till about 2, you would do just the open reduction. When they become a little older in walking age, you consider the acetabular procedure. When they're older than 3, you'll add the femur, but you need to add the femur in a younger child if it doesn't reduce without extreme tension, or if you have extreme femoral anteversion, you might have to do a derotation. So when you add the femoral shortening, I think in children usually older, 30 months of age, children that you can't get an easy close reduction, or if there's extreme femoral anteversion, so when you go to externally rotate the hip, it's dislocated, you do a femoral shortening. This picture shows a varus osteotomy. That's not my preference because actually the trochanter gets a lot closer to the ilium, and I think sometimes that becomes an impediment to reduction. This space narrows, so I just do a straight femoral shortening. I will consider a varus in an older child that has a valgus hip. So here's a child, a 4-year-old girl, and over time as you watch this hip, this acetabular index has not changed. And if you look, Shenton's line is broken even on the normal side because she's only 4, but on this side it's a lot worse, and usually in this hip that hasn't improved, we would recommend an iliac osteotomy. So the indications for pelvic osteotomy are increased anterior and anterior lateral coverage. There's different types. There's a Salter, which is from the sciatic notch to the anterior superior iliac spine. There's the Pemberton, which is more of a bending osteotomy, which changes the shape and decreases the size of the acetabulum. And then you have other, you can do a triple osteotomy. So here's a Salter, and here's a triple where you do the innominate bone and the pubic bone and rotate the hip. Here is the Dagger Osteotomy that gives you, for the purpose of this, you can look at this in different ways, but in general, the Dagger and the Pemberton are very similar. It's just the direction you bring your osteotome. The Pemberton, you cut the medial and lateral cortex. The Dagger, you only cut the lateral cortex and go between the tables to bend the hip down. And then in a skeletally mature patient, we do the periacetabular osteotomy, which basically cuts the ischium, the pubic bone, the retroacetabular and supraacetabular, and then you rotate the hip to cover the acetabulum. So it's a redirectional osteotomy. And then the dial, I don't think a lot of us do it, used to be a PAO right at the hip joint. You have salvage procedures, and there are 2 salvage procedures. The shelf, where you basically add bone to the lateral capsule, and you create a fibrocartilage metaplasia to give support for the hip, or the Chiari, which creates a fracture right above the acetabulum. You medialize this, and so the ilium becomes a weight-bearing structure. And we do those a lot less nowadays. But those are salvage procedures where you have a non-concentric hip where a periacetabular osteotomy wouldn't be indicated. So here's a 20-month-old, 4-month-old female. So this is a walking child that's older. She was treated with a Pavlik harness before, and here's her x-ray. So obviously, this hip is not reduced. It was probably never reduced. So this hip needs to be reduced, and at a walking age, we'll need a pelvic osteotomy, and you have to decide based on how difficult it is to reduce, whether you add, so here's a hip. You can see this is the one side acetabulum. This is the pseudoacetabulum. Here's a high, this acetabulum is not normal, so you have to get the femoral head in here and do either a Salter or a Pemberton osteotomy and consider a femoral shortening. So what are the complications of treatment? Well, osteonecrosis is seen with all forms of treatment, and there's different types. It's certainly worse when you have a forceful abduction. So if you have a forceful closed reduction or an open reduction where you need to do a femoral shortening and don't, or just if you do it perfectly, you can still get growth abnormality because the hip was borne out and you're putting it in. And so you can get different sorts of growth abnormality. In this, you get more of an asymmetric femoral head that's in slight varus. In this hip, you get more of a lateral arrest and medial overgrowth, and you get a valgus hip with over time will sort of become uncovered, and you got to do a varus to help it. So the diagnosis is based on radiographic findings that include all these things here. And again, failed closed treatment, it's more common, excessive forceful abduction, or repeat surgery. Delayed diagnosis, bilateral dislocation. So if you see them and they're greater than 6 years of age with dislocated hips, the textbook answer is to leave them both out. If it's unilateral, you'll be more aggressive because of the leg length problems. And in that situation, you may go up to age 8 and reduce the hip to even out the legs. So age 6, usually leave them alone. Up to age 8, the unilaterals, you want to be more aggressive. So here's a child that at 3 weeks follow-up, the hip is positioned in the harness with 120 degrees of flexion and 30 degrees of abduction, and they have a femoral nerve palsy. So that is most likely improper positioning of the Pavlik harness, leading to a femoral nerve palsy, which you can see has been a common theme of a problem with the Pavlik harness.
If you enjoyed this video, please consider leaving a like. We'd love to hear your thoughts and what you'd like to see next in the comments. Don't forget to subscribe to our channel and follow us on social media.